So today's webinar presenters are Kathleen Kerr and Kate Meyers. Both of them are healthcare consultants based here in California, and they are presenting today on some work that they created with funding from California Healthcare Foundation. If you've been around in palliative care for a while, there's a good chance that you've met one or both of them. Kathleen Kerr is really our go-to person here for analytics, finance, measurement, and other more technical issues like that related to palliative care, both in the hospital and the community setting. Kate Meyers has exceptional skills at managing large projects, and that's why California Healthcare Foundation often turns to her to help with managing some of their palliative care initiatives, including the Palliative Care Action Community, or PCAC, which we'll be hearing about today. Kathleen and Kate, I'm happy to turn it over to you.
Great. Thank you, Judy. This is Kathleen Kerr. I'll be kicking things off today for this presentation titled What We Have and What We Need, Current Community-Based Palliative Care Capacity and Resources for Bridging the Gap. Next slide. Just by way of disclosure, we have no relevant financial information to disclose to you. Next slide. So about the structure of the session today, I'll be starting this off talking about the what we have and what we need portion of the presentation, reviewing some data describing estimated inpatient and community-based palliative care capacity in California, and then thinking about need and thinking about sufficiency. Then I'll hand it on over to Kate Meyers, and she'll talk about the Bridging the Gap portion of the presentation, orienting everybody to a terrific tool developed out of the Palliative Care Action Community project, Up Close, a field guide to community-based palliative care in California. Next slide. So starting off, the Palliative Care Mapping Project. This is an effort that was sponsored by the California Healthcare Foundation, and there was an idea that for lots of reasons it would be useful to take a snapshot and get a sense of the current inpatient and community-based palliative care capacity in California, and to develop that information so we could appreciate the availability by county, to estimate the need for palliative care among Californians in the last year of life, also by county, and then to think about the sufficiency of existing specialist palliative care services by county. So that was the goal, and it's a project that I had the great pleasure of working on, and I'll share you some of the results of that today. I am going to start by spending time talking through our approach and our methods, so bear with me during that. I want to make sure you have the opportunity to understand what the numbers mean and what they don't mean. So let's dive into that material. Next slide. So some notes on the approach. First of all, we assumed that there was an equal need for both inpatient and community-based palliative care services. And the thinking was that those services provide very different types of supports to patients, obviously in very different settings. There's a different scope of those services. There's a different duration of engagement. There's different sponsoring entities. And so we really thought that we needed to make sure that there was ample inpatient and community-based palliative care. You can't have one and not need the other. Also, when thinking about sufficiency of resources or availability of resources, we didn't include hospice in the mix. This is really an investigation into the availability of palliative care. And the thinking there is that hospice is incredibly important, and that's a crucial service that's available to individuals facing the end of life. But the reality is also that it's only used by a minority of folks who die, and it's also used for a very short period of time. More than 60% of folks use hospice for less than a month, and 35% use it for less than a week. So just because hospice is available and it's being used, that does not eliminate the need for inpatient or community-based palliative care to be there to serve people leading up to the time when they would be using hospice. And it's also the case that right now, in most instances, hospice services are not available to individuals who are still seeking disease-modifying treatment. So obviously, palliative care, the idea is to fill the gap. Next slide, please. So let's start by talking about estimating inpatient palliative care capacity. We gathered this information by starting from responses to the utilization report of hospitals, a survey tool that's distributed by the Office of Statewide Health Planning and Development, OSHPD. It goes out to all licensed hospitals in the state annually. The 2014 survey would include responses describing available services in calendar year 2013. In that tool, there are questions about the presence and staffing of a palliative care program, and in that tool, palliative care is defined as an interdisciplinary team that sees patients, identifies needs, makes treatment recommendations, facilitates patient and or family decision-making, and or directly provides palliative care for patients with serious illness or their families. So a little bit of a mouthful, but it covers the key points of what a hospital-based palliative care service would be likely to do. So there's a question about, do you have this? And if you do have it, then there's some additional questions asking about how you staff that service. Next page, please. So in looking at the utilization report of hospitals, we took that list. The survey is completed by all types of hospitals, and we narrowed it down to focusing on non-specialty short-stay acute care hospitals, because those are the types of facilities that are most likely to offer palliative care, and really where the need for palliative care would likely be greatest. Once we looked at, we trimmed down that list. We looked at the response to the question about, do you have a palliative care service or not? And then we did some work to validate that, because you know, it's possible that those responses may not have been entirely accurate. It's a self-report tool. So we looked for concordance between the response in the 2014 and 2013 utilization report of hospitals, the response to that question about presence of palliative care. We looked for concordance between the site's response to the presence of palliative care as reported in the OSPRED survey, and then contrasted that to information that many of these hospitals shared in their response to an American Hospital Association annual survey. There's quite a few. The majority of hospitals in California also contribute data to the AHA survey. And so if it's yes to palliative care in AHA, and yes to palliative care in 2014 OSPRED, and yes to palliative care in 2013 OSPRED, that gave us some confidence that there really was a program there. We also did direct outreach to both health system and palliative care program leaders, asking them to validate the response, and there were many that were just incredibly generous in sharing information about the presence and, in some instances, the volume and structure of their services. And then we also, if we, as needed, went to the hospital website to look for information describing the presence of a palliative care service. Next slide, please. You know, in addition to just presence of a program, we also wanted to get a sense of the size of these programs. What was the service volume? How many admissions were they engaging with in a given year? So we did reach out to system and palliative care program leaders, asking them about how many folks their services were caring for, and many were very generous in sharing this information. We got data about volume from about half of the programs that we were able to identify. In instances where we were not able to get an actual volume figure from a site, we developed an estimate of volume based on the median service volume reported by hospitals with similar numbers of general acute care beds. So we had a median service volume for hospitals with less than 50 beds, for 50 to 149 beds, and so on. And for the purpose of this exercise, for the purpose of figuring out what is current capacity, we assume that the current volume of these services, the current number of admissions that the inpatient palliative care service was seeing annually, that was their capacity. Now, you could argue that some services are quote-unquote overstaffed, that they could see more patients than they're currently seeing. It's been our experience in working with hundreds of palliative care programs that it's far, far more likely that they're seeing as many patients as they physically can, that most of these services are stretched to the limit, that they're running as fast as they can, and that it really is more often than not, way more often than not, accurate to assume that what they're doing is what they can do, not that there's additional unmet capacity there. Next slide. Estimating community-based palliative care capacity, that was a much more complicated endeavor. It's pretty easy to figure out how many hospitals there are and to figure out how to contact them, and then to figure out how to who to talk to figure out if they have a palliative care service or not. Community-based palliative care services, so clinics and home-based services, cross-setting services that follow patients across settings, those are sponsored by lots of different types of entities. You can have health systems that sponsor community-based programs, hospices, home health agencies, medical groups. So we had to use a layered approach because there was no central repository of information describing presence or capacity here. We again leveraged data available from OSPUD. The utilization report of hospitals also includes a question about, do you have an outpatient palliative care program? And so we were able to go to that to look for sites that might be offering at least clinic-based services. There's also a similar question in a similar report that's distributed to hospices and home health agencies asking about the presence, the provision of non-hospice palliative care. So we again used those data as a starting point. We disseminated an online survey that was developed for the project, and it was distributed through the coalition. Thank you very much. And also CHAPCA, the California Hospice and Palliative Care Association. That was a very brief survey that really asked about, do you have it, and if so, how many folks are you seeing? We tried to keep it brief to encourage completion. We also, again, did direct outreach to leadership of systems with established community-based palliative care programs and reached out to folks who, individuals, program leaders who we knew, where we knew that their services existed. We did direct outreach to a number of the programs that were accredited by the Commission on Cancer because providing palliative care is part of the accreditation requirements for those sites that provide cancer care. And we also leveraged information that was available through a variety of CHDF projects and other publicly available data describing the presence of community-based palliative care programs. A survey that the Center to Advance Palliative Care did in 2013, the results of which they posted, information on the ARC Innovations Exchange page, information about programs that received CMMI Innovation Awards and so on. So we really looked everywhere we could think of to try to identify these programs. Next slide. In terms of definitions, in the OSPUD utilization report of hospitals, there's a simple question that follows the question about presence of an inpatient palliative care service that just says, do you have an outpatient palliative care program? It's just a yes, no. In a similar report that's distributed to home health agencies and home health agencies and hospices, there's a question that goes to all of the hospices and only to those home health agencies that also provide hospice services. So if your home health agency didn't provide hospice service, if you weren't licensed to do that, you wouldn't have seen this question, but there's a question that asks about provision of non-hospice palliative care. And they offer this guidance on that question. These are visits made to patients who have not elected hospice care but are receiving visits for purposes of palliation. They do not include the hospice physician consultation visits. They're provided as part of a palliative care service and could be visits from any discipline. So that's the information that's being reported in a yes-no fashion in that OSPUD report. Next slide. And then our online survey that we distributed, we tried to stay pretty close to the definitions that were there through OSPUD. We asked folks, for the purpose of this survey, a palliative care service is defined as an organized service that sees patients, identifies needs, makes treatment recommendations, facilitates patient and or family decision-making, and or directly provides palliative care to patients with serious illness and or their families. Most palliative care is provided by interdisciplinary teams of specially trained healthcare professionals who work together to address patients' physical, emotional, social, and spiritual needs. And then we clarified the types of services that we were interested in: clinic-based palliative care, home-based palliative care, so provided in private residencies, assisted living facilities, nursing homes, wherever patients reside, and then also cross-setting or mobile palliative care, where the palliative care team follows patients across outpatient settings. So those are the definitions that we were working with in trying to identify these programs. Next slide, please. In terms of estimating capacity, the volume question, we did gather some volume information from the online survey. A subset of the respondents provided that to us. Again, we had volume information from about half the programs that we were able to identify. And again, when actual volume data were not available, when we were modeling capacity, we developed an estimate of volume using the median service volume reported by each type of community-based palliative care service that we were working with. So clinics, home-based services, and cross-setting palliative care services. And then when we were defining capacity, we were interpreting that as the number of individuals these community-based palliative care services are currently caring for annually. So it's a different unit. For the inpatient side, we looked at the number of admissions, and you could have multiple admissions that were, you could have a patient who had multiple admissions, but we assumed that the unit of service on the inpatient side was the admission that the team was working with. For capacity on the outpatient side, it was the number of individuals that the community-based palliative care service cares for annually. And of course, there was a tremendous range here where you could have some programs that followed patients for only a month or two, others that followed patients for 12 months or 17 months with different frequency of interaction. So that's why we chose the individual as the unit of capacity here. And again, we assume that these programs are seeing as many individuals as they could. It's certainly possible that some of them have additional capacity that wasn't yet unmet. But again, it was in our experience that these services that exist were much more often than not serving as many people as they could with existing staff. Next slide. So for the community-based services, we have the additional step of attributing these services to counties. So for the hospitals, the inpatient services, the county where the hospital was where that capacity was assigned to. Remember, we're trying to develop an estimate of capacity by county. For the home-based palliative care and cross-setting palliative care, you could be serving multiple counties with a program that may be housed in one city, but maybe your program is technically based in San Francisco, but you're also serving patients in Marin. So for the purpose for determining estimating capacity, and a service leader indicated that their service cared for patients across counties, we attributed capacity based on the population of the county. So in the example here, let's say palliative care program X sees 100 patients a year and serves County A, which has a population of 50,000, and County B, which has a population of 100,000. In this example, we would attribute 33% of Program X's volume to County A and 67% of their service volume to County B. And that may not be entirely accurate. It might be that you're serving County A more than would be expected given their population. But for this exercise of modeling capacity, this felt appropriate as an approach. Next slide. So defining need. So we went through and defined what we meant by palliative care, and we identified as many programs as we could on the inpatient and community-based side. How do you talk about need? Well, again, for the purpose of this exercise, we considered that the populations that would benefit from palliative care would fall into three buckets. Those with serious illness that resolves. And an example here would be a patient with cancer who goes through an intensive period of treatment, is dealing with all of those things that go along with having a serious illness, but then their cancer goes into remission. Their acute illness resolves, and so their need for palliative care would also come to a close. There's also those who would have ongoing, years of need, folks with progressive chronic illnesses. You could picture a patient with, frailty or dementia where they might benefit from palliative care for years. And then those who are in the last year of life. And that's certainly where a lot of the current palliative care is being directed. It's not all of it. And that's also a population that's a bit easier to define. So for the purpose of this analysis, our estimate of need is based on the number of individuals in the last year of life, so the number of folks who die in a given year. That's what we were dealing with as our starting point in trying to determine how much palliative care is needed. It is certainly the case that individuals in those other two groups need palliative care and are using palliative care. But for this exercise, when we're talking about the need for palliative care, it's the need for palliative care in the last year of life. Next slide. So in working out that estimate of need, we needed to get information about the number of deaths annually within the state. Here we turn to the county health status profiles, which are available, developed and available by the Department of Public Health. In the 2014 document, they offer information about population, which is some information we were interested in also, and that's from 2011. They also report the number of deaths by county, and in developing that figure, they use a 3-year average, looking at all of the reported deaths within the state for calendar years 2010, 2011, 2012, and then reporting an average of those 3 years to protect against any little blips in the data. So that's what we were working from in thinking about the number of deaths annually within the state. Next slide. And then thinking about what proportion of that whole population, of all these patients who die in a given year, how many of them would likely need palliative care? Well, here we turn to some work that has been done in Europe and Australia where they've undertaken the exercise of estimating population-based need for palliative care. It's not surprising that these studies would come out of other countries that have national health systems. They can have a more population-based perspective. And so I give you a reference for a terrific article that sort of took 3 studies of estimating, of doing a population-based estimate for palliative care need, considered the pros and cons of each of those approaches, and then presented a new approach. You can get that from the Journal of Palliative Medicine. And we mirrored our approach to work that they had done. We developed a low estimate need and a high estimate of need, since this isn't really something you can pinpoint. The low estimate of need is based on the number of individuals dying of 7 conditions that were specified in the county health status profiles, and conditions where there's commonly a need for palliative care, either on the inpatient side or on the outpatient side, or both. So cancer, all types, diabetes, Alzheimer's disease, heart disease, cerebrovascular diseases, chronic lower respiratory diseases, and liver disease and cirrhosis. So you can certainly make a case for adding some to that list, but it seems like a nice starting point of these chronic progressive illnesses, which typically point to a need for palliative care at some point. The high estimate of need, a much more inclusive interpretation of who might benefit from palliative care, is all deaths, excluding those that were caused by accidents, homicides, or suicides. So basically, all deaths that were related to an illness. So a much larger number coming from that estimate. Next slide. So here are the numbers, really interesting to me. Low estimates and high estimates. So in terms of all deaths, the number of deaths within the state that we were working from, a little more than 238,000 annually. Look at the high estimate of need, so all deaths except those caused by accidents, homicides, and suicides, more than 220,000. 93% of all deaths would fall into that definition of how many folks are likely to need palliative care in the last year of life in California. And then our low estimate of need, one that's based on the occurrence of those specific conditions, not quite 146,000. And that maps to 61% of all deaths. So if you're thinking about the need for palliative care using our model, it would be between 61 and 93% of all deaths annually. Next slide, please. In terms of inpatient palliative care, prevalence, capacity, and sufficiency, it's a little stunning to me, I must say, at this point, to go through months of work to develop these data, and here it is, sitting on just one slide. Among the 369 acute care hospitals where we were able, that were included in our non-specialty acute care grouping, we validated the presence of 186 inpatient palliative care programs. So a little more than 50% of the hospitals had active services. Those services existed in 39 of 58 of the counties in California, so 2/3 of the counties have inpatient palliative care services. I should say that those 39 counties have something like between 97 and 98% of the population for the entire state. So there's a very strong link between being a population center and having access to inpatient palliative care. We estimate that as a group, these programs are contributing to more than 72,000 inpatient admissions each year. So that's really impressive to me if you think about things where things stood 10 years ago. If you interpret the current capacity, so the number of inpatient admissions where palliative care is being delivered, if you think of that in relation to the estimate, the low estimate and the high estimate of need, the current capacity is between 33 and 50% of the need. So using a high-end estimate, we're covering 33% of the need. Using the low-end estimate, we're covering 50% of the need. Next slide, please. In terms of community-based palliative care prevalence, capacity, and sufficiency, we were able to identify 189 community-based palliative care programs, a combination of clinic-based services, home-based services, and cross-setting services. These were sponsored by 147 separate organizations, so you have some organizations that offer both clinic and home, or clinic and cross-setting, or some combinations thereof. The programs are available in 36 of 58 California counties, so 62% of the counties now have some community-based palliative care available. Even though the number of services is quite similar to what you see on the inpatient side, as a group they are smaller. They are contributing to the care of 53,500 individuals annually, and that represents 24 to 37% of the need. So next slide, please. So if you think of that, if you just look at that in terms of the numbers, estimated need and sufficiency, you have our high-end estimate of need, so not quite 222,000. Our low-end estimate of need, not quite 146,000. Inpatient palliative care capacity, not quite 73,000. And community-based palliative care capacity, a little more than 53,000. So there's a big distance between that 53,000 and 145,000, a big distance between that 53,000 and the 222,000. Next slide. So one thing I wanted to alert you to, which we're very excited about, is that there's an interactive tool on the way being developed by the very talented communication and publication staff at CHCF. The data will be available through interactive maps. That should go live in February of this year. You'll be able to look at capacity, need, and sufficiency for both inpatient and community-based palliative care presented for each county. And we're currently exploring mechanisms for incorporating ongoing updates of this information. We realize that there's new services coming online all the time. There's also some services, unfortunately, that fold. There's also quite a dynamic environment in terms of the volume of these services. So we'd love to be able to update this information regularly to reflect the dynamic nature of the field. Next slide. So here's just a presentation of the beta version of the interactive tool that will be available. This one is talking about inpatient palliative care need and sufficiency. So in the map that's on the left, you see a presentation of the estimated palliative care need, so the number of patients needing palliative care in the last year of life. The counties are outlined on the map of the state, and then the coloring reflects the lighter the color, the fewer number of individuals. So if you're in that very dark brown, then there's more than 10,000 individuals annually who will need palliative care. If you're in the lightest color, and there's 4 counties that fit into that category, there's fewer than 100 folks each year that would likely need palliative care. And then the map on the right shows the capacity in relation to the need, which is our way of expressing sufficiency. So if you're able to, if there's no inpatient palliative care in your county, and there's 19 of those counties, then you show up in white. If your current capacity is able to accommodate less than 25% of the need, then you're in the lightest shaded blue, and so on. Next slide. And then you'll be able to click on each county and then get some more detailed information there. Here, what we're using as an example, Shasta County. So that's highlighted on the map there, and you'll see that you'll be able to see some information. It gives you the population estimate, and this is reflecting the census figure from 2011. Gives you the number of annual deaths, and then it gives you the estimate of need. So what's reported is the mid-range between the high and the low estimate of need. So the low estimate of need, so that estimate that's based on specific conditions, that was 1,191. The high estimate of need, so all deaths except for accidents, homicides, and suicide, that was 1,850. And the midpoint between those two numbers, which is what you'll see on this map, is the estimated need, which is 1,520. Next slide. And then in the figure on the right-hand side, you'll be able to look at what the sufficiency is like. So estimated sufficiency in Shasta County for inpatient palliative care is 22% of the need. So it's 18% of the high-end estimate of need, 28% of the low-end estimate of need. And you'll be able to look at this for any county in the state. There's also a nice summary of services by county that'll be available. We'll be sending everyone who attended this webinar, who signed up for this webinar, an email letting you know when this tool becomes available. Next slide. So a little bit about the limitations and remaining questions. I think like most projects like this, or this is the first time that I've seen a project like this done within California, certainly you wind up with really more questions being raised than were answered. And that's a good thing, I think. So in terms of limitations, how you might interpret these data, first of all, most of it is self-reported. Almost all of it is self-reported. So there's obvious limitations there. There's no validation in terms of making sure that what people say they have, though I imagine most folks are trying to be honest when they're offering information. I think the reason why there's some limitations to self-reporting is that there's different ideas of what counts as palliative care. We had a few definitions of palliative care that were used for the community-based palliative care services, and even within interpreting those definitions, there's variation. Another sort of limitation or confounding factor is that services are sponsored by many types of entities in the outpatient world, and there's no central place where information is reported about the presence or structure or volumes of these services. We made a good faith effort to try to reach lots of different types of organizations, but we almost certainly missed some services. And I would say this is especially so in the home health and medical group sponsored services. I think that's where we're most vulnerable for having missed those, which is why we're very interested in having an updatable tool through the California Healthcare Foundation website. And it's also a highly dynamic environment. New services are popping up all the time. Volumes are changing all of the time. And so this snapshot could become outdated the day after a program just hires a new nurse to start to take on more volume. We didn't make much of an attempt to gather information about structures and processes or outcomes of services. We do have some information about the staffing of many of the community-based services and what their scope is, but we didn't gather information about the types of patients that they're targeting, and didn't get a lot of good information about the duration of engagement, and we didn't try to get any information about outcomes. And we also didn't gather any information about the patients. We don't know about the diseases and their conditions, or really about the payer mix. So who's getting palliative care now in relation to who's paying for their health care. Next slide. So a few take-home points, very simply, is that inpatient palliative care is available in most counties in California and in most hospitals. More have it than don't. Community-based palliative care services are spreading rapidly and are also available in most counties. But even so, there's still lots of unmet need for both types of services. And with that thought, I'll hand this over to Kate Meyers, who can talk about another really cool resource that was again sponsored by the California Healthcare Foundation to help those of you who are interested in bridging that gap in the outpatient world to do so in a smart way.
Thank you so much, Kathleen. And yeah, thank you, Keita. So in thinking about this context that Kathleen has described so helpfully about the current capacity and current need for palliative care in the state, what I'd like to do over about the next 15 minutes or so, making sure to leave time for your questions at the end, is to talk about some work that the California Healthcare Foundation has supported and led to help strengthen and grow that capacity part, the community-based palliative care service capacity. So as part of this, I'll be talking a lot about a resource that we developed that came out of the Palliative Care Action Community. Next slide, please. So why the motivation behind this work for the California Healthcare Foundation was really a little bit about what Kathleen just described, that hospital-based palliative care programs are well established around the state and around the country and are more prevalent than community-based palliative care. But community-based palliative care is growing. Organizations are doing this work, but there have been sort of few mechanisms for the organizations and programs in community-based palliative care to network with each other. Many of these programs have developed in relative isolation. There's a lot of diversity in the types of organizations that offer community-based palliative care. So in a lot of instances, we hear from organizations who have really just been doing this on their own and would relish the opportunity to learn from other people who are doing similar work. So the foundation recognized that there was a need to really provide a forum for organizations doing this work to learn from each other and to learn while they're doing this work, recognizing that we're building the work as we go. Next slide. So to help meet that need and to provide that forum, the foundation created what was called the Palliative Care Action Community, which was an action community consisting of 21 California-based, community-based palliative care provider organizations who worked together for a year, and I'll talk a little bit about that process in a moment. What I want to point out here is just the variety of the types of organizations that were involved in this action community. As the slide depicts, we had everything from small or single hospital health system teams to very large multi-hospital regional health systems, as well as medical groups and home health and hospice agencies. And these organizations delivered community-based palliative care in different settings, including clinic-based services, home-based services, and distance or phone-based as augmentation to either clinic or home-based in these cases. And the volume of the programs varied quite widely, from at the time that the program started, about 30 patients per year to up to 2,600 patients per year per program. So despite these diverse circumstances and diverse types of organizations, we found through the course of the action community that there were many shared experiences and challenges, and there were many opportunities for organizations to learn from each other, whether they were learning from an organization similar to their own or different. Next slide, please. So what the action community tried to provide was an infrastructure for shared learning. And how do we define this? I just want to point out this is different, or was different, from what is often thought of as a learning collaborative, kind of the IHI learning collaborative model, where in those circumstances there's a fairly defined set of interventions that a group is working on implementing together. With our action community, it really was different than that. There wasn't a defined change package. There wasn't a defined set of services that we thought all teams should be implementing. Really, the content of our work together was determined by the needs of the participants. And we recognized and talked with the participants early on about the fact that this was an emerging and evolving field, and that they were helping to write the playbook for community-based palliative care and helping to create the learning for each other and for the field at large. Excuse me. So the focus was really on peer-to-peer learning and networking opportunities. Next slide. So in terms of the logistics of how our action community worked, we basically met monthly, either in person or in virtual webinar or conference call settings for the course of a year. And this provided administrative and clinical leaders from these community-based palliative care programs and providers from these programs to talk really openly about how they were doing things, specific nuts and bolts of running their programs, operational, clinical, measurement issues, very much focused on sort of practical details of running day-to-day, running their programs. We also invited in some outside speakers to talk with our teams in different venues. And throughout the course of the action community, again, based on the needs of the members, we wound up creating some discipline-specific work groups, for example, social worker-specific and physician-specific, where we met offline to talk about their unique issues and challenges, and also offered some sort of more narrowly focused topic-specific subgroup calls on special topics as they came up. Next slide, please. So as we went through the course of the action community, we heard so much from participants that they were learning so much from each other, and we were learning so much from them, that we really wanted to be able to capture what was learned during the course of that year together and to share that information beyond the action community. So the way in which we've tried to do that, there's a few ways that I'll describe, include this field guide called Up Close, a field guide to community-based palliative care in California, which is available on the CHCF website. And what this field guide does is attempts to sort of document the community-based palliative care key considerations and approaches and challenges that our action community members expressed and experienced. So this, again, isn't a description of what a community-based palliative care program should look like, but it is a description and provides a lot of real-life examples of what organizations delivering community-based palliative care in California look like, how they do things, and what all organizations trying to do these types of services should be thinking about. So it provides a lot of food for thought and specific practical examples. Also through this process, we worked on developing and sharing some specific trainings and tools, which I'll talk about a little bit later on. Next slide, please. So what does the field guide have in it? Of course, I hope you all will go and take a look at the field guide and review it after the webinar if you haven't already. But as a general overview, again, it contains practical information. What do organizations need to be thinking about, planning for, and addressing as they develop or try to grow or strengthen community-based palliative care programs based on the experiences of these action community members? We also tried to focus a lot on moving from concept to practice. So you'll see when you review the field guide in every section, there's a subsection called From Concept to Practice, where we provide descriptions, specific descriptions of how different PCAC teams approach those issues. And some of those are organization-specific and called promising practices, where our teams themselves noted what they're doing, and other teams said, yeah, that sounds particularly interesting and innovative and potentially helpful. And so we tried to call those out as promising practices. The field guide also contains 4 case studies of different organizations, which I'll talk a little bit more about down the line, as well as some descriptions of innovative models that came out of our various webinars and presentations from outside experts, and a number of other resources, which I'll describe. Next slide, please. So what I want to do over the next few minutes is really just give you some highlights about the different pieces of content and sections within the field guide. And in the interest of time, I might run through a little bit of these quickly so that we can get to questions as well. But the content is there, and of course the field guide can provide you the full details. So starting off, the field guide presents information on features and models of community-based palliative care. This includes, what can these types of programs look like? And the way we described community-based palliative care was non-hospital and non-hospice palliative care services. This section also goes into how patients are identified or can be identified, including work around particular conditions or looking at patients in certain settings or certain utilization triggers. It also goes into descriptions of what types of services are offered by the provider team and how are services commonly structured in community-based palliative care, focusing around clinics. Are they standalone clinics, co-located with different specialty groups or embedded with certain specialty groups, home-based services, and distance again. This section also goes into some detail around, what is the palliative care team's role relative to other providers, and what does a community-based palliative care service need to think about in that respect, whether it's a consult service or a co-management service, or whether they become a primary caregiver for a patient that comes onto their service, or whether it's a mixed model depending on the patient's needs or the referring provider's needs. This section also goes into some specific practical examples of what do community-based palliative care services do during or before the first visit happens, during that first visit, and in subsequent follow-up care. So again, all of these pieces of, how does community-based palliative care work? These are based on the experiences of the palliative care action community, so it's not to say it's the only way to do things, but we hope that it provides some useful food for thought and practical examples for organizations who have these services and are looking to grow them or who are considering implementing community-based palliative care services. So some examples. Next slide. So this is an example of a figure or a table that's within the field guide, and this information describes, what kinds of services are offered by some community-based palliative care teams, our PCAC member teams. And this data came from a survey that was conducted with our members in 2013. So what I think is interesting about this slide is you can see that there's some consistency among the services typically provided in clinic and home-based programs, though some differences. But another interesting point here highlighted is that spiritual support and case management seem to be typically less universal, at least among our PCAC members. So there's opportunity and room for capacity building there as well. Next slide. Another example here, and I won't go into this in detail, but just wanted to use it as a kind of an illustration of the kind of information that's in the field guide. This is an example of how different teams structure their initial visit with their patients. And so wanted to point out in the examples here, different types of providers can be involved in these initial visits. They can take differing lengths of time. These teams, for example, went from 60 minutes on one team potentially to 2 hours on another team for an initial visit. And the goals of those visits can differ. So really, again, the interest in pointing out this information is to show the variety of ways in which the PCAC teams are doing things, and we know that that's probably true across community-based palliative care teams in general. There's a lot of different ways to do this work. I should also say with this type of particular example, these descriptions came up during our learning sessions. There wasn't a sort of formal analysis of all of the models that our PCAC teams used, but we just wanted to capture some examples of how teams are doing things. Next slide, please. All right, so I'm going to try to speed up a little bit here so we can get to some questions. The field guide also contains information on the interdisciplinary team that typically comprises community-based palliative care service. How can these teams be staffed? What disciplines? What would the FTEs potentially look like? And what's potential visit volume? Again, this is information that came from our PCAC teams from surveys. So they provide examples of staffing and volume, but are not meant to be interpreted as ideal or as targets. It's just some information from these teams. The section also talks about staffing strategies for these types of teams and issues around team functionality and how teams can work effectively together. Next slide. So again, this is just an example that came out of our learnings from surveys of our PCAC members. And the takeaway here is that team composition, the interdisciplinary team composition, varied widely across our teams and across settings. But we did notice that because the survey was conducted twice, we noticed that our teams became more interdisciplinary over the course of the action community, which we took as a positive sign. Next slide, please. So this is an example of what I was talking about from concept to practice, where we give some really detailed specifics about how a PCAC team does something. So I won't go through the specifics here, but this example was around how a team can staff their palliative care services across settings, in a setting where there's both an inpatient and an outpatient service. This provides a little bit of insight from a team that shares their staff on the inpatient and outpatient side and what they saw as some of the advantages and challenges of that. Next slide, please. So there's a section as well on partnering with other care providers, including why that's important, some approaches to building relationships, how palliative care teams can work with referring providers to support appropriate referrals, and what some of those first steps are in working together and building a relationship when a referral happens. There's also some information in this section about how to be responsive to referring providers and helpful without overwhelming the palliative care service, and some ideas from the PCAC teams about how to build interest in palliative care services among providers who may be reluctant to refer, and how to work with situations where there may be disagreements with the referring provider. Next slide. So again, this is another example of a promising practice, this from our colleagues at Optum around their approach to building partnerships and relationships with referring providers. And their approach included really getting out there on the ground with the referring provider groups and attending in person patient care conferences with them to discuss difficult cases and to discuss how their services could support both the patient and the referring provider in those situations. So again, just another example of how teams are doing things. Next slide. And this is a second example of how one of our teams is trying to work more effectively with referring providers, where they have the primary care provider or the oncologist, in this case, present when they discuss goals of care so that everyone's on the same page. So again, just providing more specific examples of how teams are working on these issues. Next slide. So we also have a section on coordination and transitions, recognizing that the palliative care service does not act in isolation and needs to be effective at partnering with related services within their organizations, like complex case management or other specialists like social workers that are oncology social workers, for example, or home care services. And what do those transitions look like for patients who weren't in the last year of life and can transition back to usual care? And what do transitions look like when patients are appropriate and ready for hospice? Next slide. So I won't go into the details on this slide, but this is an example of how our PCAC teams are dealing with some of the challenges with transitioning patients from their palliative care service into hospice care, including some of the common challenges listed there on the left and some sample approaches that teams discussed during our learning sessions about how they work to address those challenges. Next slide. So a very important part of our field guide and the tools that came out of it is around measuring opportunities for community-based palliative care and impact of community-based palliative care services. So tools created by Kathleen Kerr and her colleague Brian Castle from the Virginia Commonwealth University are described in this section, including what are called an opportunity analysis and supportive care calculators. Because of our limits on time, I won't go into too much detail about what these tools can do, but I strongly urge you to look carefully at that section of the field guide because our teams universally, practically, found these tools very important and useful to them as they worked on convincing leadership of the relevance and importance of their services. Next slide, please. This provides a bit more detail on the opportunity analysis and the supportive care calculator tools and what they can do. Again, because of time, I think I'll skip through this. Next slide, please. But just to entice you a little bit more to look closely at those sections of the field guide and these tools, this is an example of an analysis that came out of using the opportunity analysis tools, where one of our PCAC teams basically compared a number of quality metrics for patients who received early palliative care, that is earlier, or more than 90 days, their initial palliative care contact was more than 90 days prior to their death, versus late palliative care. So the differences there were quite interesting and significant for them, and helpful in convincing leaders in the importance of the palliative care services and of earlier introduction of palliative care services. Next slide, please. So there was also work and description in the field guide around quality improvement and the importance of setting aims. Our teams developed aim statements early on. Some examples of those are here, and we revisited them throughout the action community period to assess how teams were doing and to encourage tracking of that during the course of the action community. Next slide. We had teams, about a third of them fully achieving their aims and making progress on another third, and not surprisingly in some ways, making limited progress on another third of their aims. But we thought it was very important that teams be tracking what they wanted to accomplish during this time period and how they were doing. Next slide. All right, I think because of the amount of time we have, I want to allow time for questions. I'll refer to the fact that we also have some fantastic case studies in the field guide which go into more detail. And next slide. We also have some information from each of the, or many of the outside experts that spoke to our team, focusing on a number of different interventions. Next slide. And our appendix lists a number of tools that are very useful, including where to find the opportunity analysis and supportive care calculators, which are available on the Coalition website. The link is there, as well as the CAPC Payer Provider Toolkit, and an online training course that was developed during the course of the PCAC in collaboration with the CSU Institute for Palliative Care around excellence in documentation. Next slide. And just want to acknowledge our collaborators in this work for both the PC Mapping Project and the Field Guide on this slide. And with that, we'll go to the next slide, please. All right, so I'm sorry we only have a few minutes, but I'd love to, Kathleen and I would love to answer any questions that you have about either the Field Guide or the PCAC's work or the Mapping Project work.
Thank you, Kathleen and Kate. I really appreciate all that informative presentation. For those who are listening to this webinar and would like more information, Kathleen and Kate will also be doing a presentation at the Coalition's annual conference April 14th and 15th in Sacramento, so sign up for that. Just a reminder to type your questions in the Q&A or chat box. Kate, I think we have some questions already.
We do, and I do want to remind everyone that you'll be receiving a follow-up email, that will include links to both the recording of the webinar slides, and I'm also going to include a link to the field guide, so you'll have that easily accessible. Here's a question. What examples of successful payment models have you seen for community-based palliative care? The cost is estimated to be between $400 and $900 PMPM.
Per member per month.
Per member per month. How do we pay for it?
Kate, do you want to go or should I?
Go ahead.
Yeah, you know, that's the $64 million question, isn't it? How can you get this paid for? I think that having a sense, I think step one of that is sort of knowing what your costs are. So the cost estimated to, you know, between $400 and $500 per member per month. I've seen slightly different estimates as well. I think that the core strategy is to work with the entity that has risk for overall health expenditures. So I think many services have been successful in contracting with payers, health plans, or medical groups that have full risk for a population, working with them to identify the magnitude of expenditures that are happening for patients who would be palliative care appropriate, figuring out the proportion of that expenditure that may be avoidable if these patients were better supported through a palliative care service, and then working through a negotiation. I should mention another California Healthcare Foundation project is doing just that. There's a payer-provider partnership initiative where there are 10 dyads of payers and provider organizations that are, the provider organizations are currently providing community-based palliative care, and they're actually spending 6 months working with an identified payer or an identified entity that is at risk to figure out just how to do what you described. How can you cover the cost of providing these critical services in a way that's affordable to the payer and allows for a sustainable intervention on the part of the provider. There's some good information also in that payer-provider toolkit, which you're gonna, which is referenced in the slides. Kate, anything to add to that?
No.
Great, thank you. Does an organization have to be Part B certified to bill for palliative care?
It depends on who you're billing. There's different requirements for billing for palliative care depending on who you're billing and what you're billing for. So it's a little beyond the scope of this webinar.
Okay, thank you. FACE community nurses are a group that would be a great asset to community-based palliative care providers. Can you suggest a good way to connect these groups?
Could you say again what the group was? I heard community nurses, but there was a word that preceded that.
FACE community nurses?
Oh, FACE community.
Yeah, so like parish nurses. Kate, do you want to?
Well, I mean, I haven't thought about that before, but I think part of what each of our organizations in the action community, or some of them, tried more explicitly to do was to figure out what resources were in their communities, their local geographic communities that could become potential partners and provide assistance, whether it was with, you know, home-based kind of drop-in visits or so forth. But I didn't hear of anyone working specifically with faith-based nurse communities, but I think it is an interesting idea, certainly.
Do you have any ideas on why the spiritual care services were the lowest services in the programs that you looked into?
Wow, that's a great question. I think that while there is very commonly a chaplaincy program available within hospitals, it's not quite as common to have a chaplain affiliation with an ambulatory practice or, say, a home health service. And so I think that's one of the reasons why there wasn't an existing service there to leverage. I think also, quite frankly, it probably has to do with the payment model, where a chaplain obviously can't bill. So it's more difficult for a program that is still working out its revenue stream and how they're going to be sustainable to bring on those individuals. But it's a real clear opportunity to enhance the scope and really the efficacy of these services to build up spiritual care capacity, both in forms of dedicated professionals and then also building competence and confidence amongst other disciplines, so making sure that everyone on your team can do a good spiritual assessment, even if you don't have a dedicated chaplain.
Great. Thank you, Kathleen and Kate. For those of you who had questions that we didn't get to, we will forward them to the speakers to follow up with you directly. So join with us. If you're not already a member of the coalition or participate in this work, join the coalition. There's a lot of great benefits that you get, including discounts on education and the Coalition's annual summit, which is going to be April 14th and 15th in Sacramento. And this is really an opportunity for us to come together as a palliative care community in California and speak with a single voice and shape the future of healthcare in California. The brochure will be coming out shortly. Look for that in the mail. It includes a lot of PCAP features, including office hours where you get to speak to people like Kathleen and Kate one-on-one, poster sessions, and leadership awards. If you want to submit a poster, please go ahead and send that in to us, your proposal. And if you have somebody that you're working with who is a leader in palliative care that you think should really get recognized, take a close look at that application. It's very easy to submit, and they also get $1,000 as well as support to attend the conference. So it's definitely worth taking a look at. We do have monthly PCAP webinars. We keep our proposals, our schedule, we focus on really timely and cutting edge issues so that we keep monitoring what is most timely to bring to you. And in February, we're looking at doing a webinar on public policy. There's a lot of happening in public policy related to palliative care in California. So stay posted for that. Watch for your email. And we just want to thank you for joining the webinar today. Have a great day.